Hi, hello. I'm Sherry Hughes, and on behalf of my co-chairs, Marcia Levy and Joan Weil, welcome to all of you who have come here today, to those of you out there who are joining us remotely to our third annual Women's Health Symposium today. So thank you all for being here today, and thank you for your support of the hospital. I would also like to say welcome and a special thank you to our guest speakers from our great partner, UCSF. And finally, the members of the symposium committee to stand. Thank you. And now I would like to introduce John Henley, who's the CEO of Snow Valley Hospital.
Thank you. Thank you, Sherry. And thanks to Sherry, Joan, Marsh, and the committee for their support and for helping make this happen. It's an incredible event. We're so thankful for that. Before I start, I'll put this up. Everybody remember last year? That was my takeaway from last year. I tried to distill things down to one thing I can remember. And that's my one thing. I asked Andy before today's event, I said, are you going to add something to my fruit salad this year? And the team said, well, we might not add, but we may do some subtraction. Listen for the subtraction. I'd like to thank Dave Peer. Dave's here somewhere. Thank you for making this happen. And I'd also like to call out our hosts, the Hannah Center. They are a vital part of our healthcare team. And we're actually going to be here next Wednesday in the ribbon cutting for something I'm really excited about, their mental health hub. The hub's been designed to extend what Hannah already does to the rest of the valley, serving the youth across our valley and their families. So just a shout out to Hannah for that great work. So we're fortunate to have this great partnership, this great relationship. Sonoma Valley Hospital benefits in so many ways. This year we've made, since I last spoke to you, we've made a couple of new additions to the relationship. We've recruited our new chief medical officer, Dr. Sujata Sakran, from the ranks of UCSF. So welcome, Sujata. And we're happy to announce we'll be starting a uro-oncologic clinic this summer with world-renowned Dr. Peter Carroll. With that, I'd like to introduce our moderator, the chair of neurology, and a professor at UCSF's Weil Institute of Neuroscience. Oh.
All right, well, thank you all very much for being here, and thanks for having us again. We're thrilled. As John said, I'm Andy Josephson. I'm in the neurology department at UCSF, and I'm really delighted to be back. Last year, we had a great event on neurodegenerative diseases. Alzheimer's and things you could do. There's a lemon rolling around, things you could do to prevent cognitive decline. And then in the question and answer session, about 80% of it was about sleep. So we said, okay, well, Joan and Marcia and the whole committee said, maybe we'll do sleep this year. So we're so appreciative to have us back and tackle this. Now, sleep is something that, of course, is important to all of us. It's something that, if you're like me, you worry about a little bit, try to understand what's the best thing to do. And like a lot of things at UCSF, we have this wonderful way of attacking these problems where we think about how to make them better clinically and things we can all do to get better sleep. We do cutting edge and really novel research to try to figure things out and try to design new therapies and new understanding of these disorders. And then we do a lot in terms of education, our community and the medical students and residents and fellows who train with us. And you're going to hear a little bit about each of these today as we tackle this particular problem. We have 3 different speakers, and when those speakers are done, we'll have a Q&A session. So the way it works is you all have a little notebook with you, Please feel free as we're going to jot down a question, one per page, please, right, big enough that I can read it, and then pass it over to the aisle, and there'll be folks who come by at the end and collect them after our 3 presentations, which we're excited about. Before we get to the presentations, I just want to say one thing from a neuroscience standpoint about how excited we continue to be about our unbelievable partnership with Sonoma Valley Hospital. We are about 5 years into, as many of you know, partnership in neurology where we provide all of the neurologic care for patients who show up at the hospital, Valley Hospital, with neurologic emergencies. So if you have a stroke here, God forbid, and end up at Sonoma Valley Hospital, our physicians are there and can provide the same level of care as if you show up at the UCSF hospital. And that, thank you. This partnership has been so much better than asking patients and their families to get on a helicopter or have to go a long distance to get the kind of care that they deserve and need. And we've just so appreciated this partnership, and we'll continue, as you heard from John, to build more and more connections with UCSF and UCSF Health. So it's something that is really, really important. Okay, so let me start it off. We have 3 unbelievably great speakers. They're each going to give about a 10-minute talk, and then we'll have time for question and answer, and they're each going to talk about something totally different. We're going to begin a little bit with the basics, but also then with the complexities of complex care of sleep disorders and sleep problems with Dr. Liza Ashbrook. Liza is an associate professor of neurology. She is one of the top sleep clinicians that you'll ever meet. She cares for people with sleep disorders, but does it in a very interesting way, in that she has a sleep clinic that she runs purely focused on neurologic and psychiatric problems that manifest in sleep. Liza also, getting to the education part, runs our sleep fellowship with trainees who are neurologists, psychiatrists, and pulmonologists who want to learn more about becoming a sleep doctor. Learn from Liza. So I think you're in for a real treat. We'll start off with Dr. Liza Ashbrook. Liza, come on up.
All right, can you hear me okay? Great. So I'm excited to be here to talk to you all about sleep. So we're going to start broad, talk a little bit about why we sleep. We'll shift to how sleep changes as we age, and then we'll talk about sleep in women, and then end with some tips around sleep. So let's start out with, why do we sleep? Seems like a question you should intuitively know the answer to. Presumably you all slept last night. But actually, we don't have one unifying reason why sleep is so well preserved over the ages across species. We have some ideas, some of which I've highlighted here. We sleep to preserve our energy, to replenish our energy stores. We sleep to cleanse our brains from all of the waste we produce during all those hours of thinking. A lot of that gets cleaned out while we sleep at night. We know sleep is vital for memory consolidation, as well as for forgetting things we don't need to remember. And yet, some have called sleep one of the few remaining biological mysteries, one of those things we don't still fully understand. So, it may seem like a lot on this slide, but I wanted to share how sleep changes as we age. So we have changes in the percentage of sleep stages on the right, and then some different ages on the left. So starting out, in young children, we see more very deep sleep, called slow wave sleep, or N3. That's why kids can seem so hard to arouse when they sleep. And of course, longer sleep in young children. As we move to adolescence, our amount of slow wave deep sleep decreases. We also see a shift to a later circadian timing, meaning teens become night owls. While we don't totally understand the neurobiology behind that, we have some theories about why it might happen. They're becoming more independent, breaking free from supervisors, and up later at night. But this is something that's repeatedly observed. As we move into adulthood, we see that the amount of sleep decreases slightly. Our need for sleep doesn't decrease, but we're just not as good at getting that sleep as we get older. and our amount of wake overnight increases. We're not as good at staying asleep. And then as we get into older adulthood, we see that the amount of slow wave sleep decreases. We also see a shift to an earlier circadian timing. Following adolescence, actually, we slowly shift earlier, and sometimes people become extreme morning larks as they get older. So let's talk about pregnancy. There are so many physiologic changes that happen in a woman's body during pregnancy. Many of them affect sleep, and I've highlighted a few here. So we have huge increases in hormones like estrogen and progesterone, and these can affect sleep. Estrogen and progesterone, specifically progesterone, make people very sleepy. They're sleep promoting, and most women report extreme sleepiness early in pregnancy. We also see that there's a physiologic anemia as blood volume increases, and this can be connected to restless leg syndrome. There's actually changes to soft tissue and mucosa that can affect the airway, can affect breathing during sleep, and this can increase risk for obstructive sleep apnea in pregnant women. And then we also see changes, of course, as the fetus grows, it pushes down on surrounding structures, can press down on the lungs, press down on the stomach, increasing risk for acid reflux. So I've listed here a number of issues that can disrupt sleep in women who are pregnant. So this includes restless leg syndrome, insomnia, sleepiness, obstructive sleep apnea, and acid reflux. And this matters not only because it's uncomfortable, disruptive for the woman, but it's actually been connected to some really serious health issues during pregnancy. So disrupted sleep increases the risk of preterm birth, gestational diabetes, high blood pressure, preeclampsia, as well as mood and risk of depression, both before and after delivery. So here I just wanted to share with you some data from a research study. So I want to highlight here, you see a number of bars on this chart. This is a research study that looked at snoring in pregnant women. And to give you the take-home point, what they saw is that it wasn't about the weight of the women. They separated the women into 4 groups. Those who were lean versus a BMI greater or body mass index greater than 30, and those who snored and didn't snore. And they actually saw that it wasn't about weight, but about snoring that increased risk of gestational hypertension and preeclampsia. So snoring alone in these women was a serious risk factor for concerning health outcomes during pregnancy. And that's so important because it is treatable. This is a study that looked at CPAP. So this woman here is wearing CPAP. This is one of our mainstays of treatment for obstructive sleep apnea. It's a machine, you wear it while you sleep. Many of you are probably familiar. And it pushes in extra air to keep the airway from collapsing. And in this study, I'll just draw your attention to the bars on the far right. They showed that in women with preeclampsia, obstructive sleep apnea could be treated, and the CPAP actually normalized cardiac output. So there's a bunch of bars, and none of those women on the left got CPAP except for the final bar in black. And you can see when you compare that to the control group, it actually normalized cardiac output in these women with preeclampsia. So these serious health outcomes can be treated in pregnant women if we detect it and get them to treatment. Insomnia can also be treated in pregnant women. Of course, there's concerns about using medication for insomnia, particularly in people who are pregnant. And our first-line treatment in sleep medicine for insomnia is something called cognitive behavioral therapy for insomnia. But I'll highlight some of the principles of what we call CBTI. This includes reducing time in bed to better match where people are actually sleeping, relaxation training, firming up the association between bed and sleep, and confronting some of the maladaptive thoughts around sleep. And actually, a team at UCSF, Andrew Christo was a part of this, led by Jennifer Felder, a colleague, looked at web-based cognitive behavioral therapy for insomnia and showed that this actually decreased insomnia in pregnant women. Not only that, but it decreased actually symptoms of anxiety and depression as well. So now let's switch to talking about menopause. So there are so many factors that affect sleep in menopausal women. And I've highlighted just a few here. So of course, there's the hormonal changes that cause hot flashes and night sweats and can be very disruptive to sleep. But there's many other things going on in the lives of women who are menopausal age. Often new medical issues are arising. There can be a lot of stress, and work-life balance can be challenging at this age. Also, women of menopausal age have aging parents commonly, and caregiving duties commonly fall on women. And so many women are juggling taking care of aging parents as well as children, which can lead to the burden of menopausal symptoms. So one big thing that occurs during menopause, of course, is hormonal changes and the reduction of hormones that leads to these vasomotor symptoms, specifically hot flashes and night sweats. But it may be underappreciated that actually a core symptom of menopause is sleep disruption. It's incredibly common, and that can also be treated. Insomnia is very common among women experiencing menopause, and we know that hormone replacement therapy can help with insomnia, but cognitive behavioral therapy for insomnia has actually been studied and been shown to be effective for women in menopause despite hot flashes. Even simply reducing time in bed to better fit when a woman is actually sleeping has been shown to be effective. And then other symptoms women experience: sleepiness, obstructive sleep apnea. We know that progesterone is a respiratory stimulant. What this means is that women who are premenopausal have lower rates of obstructive sleep apnea. Progesterone is actually protective by promoting breathing, but as progesterone levels fall, we see similar rates between men and women postmenopausally with obstructive sleep apnea. So it's common that we see this symptom emerge in women, and that can be a cause of some of the sleep disruption as well. We also know restless leg syndrome is more common in women and more common with age, and this can be treatable if detected as an additional sleep disruptor. So I'm going to end with just some tips for sleep. So there are many things you can read on the internet about tips for sleep, but if you're struggling with sleep, one of the biggest things you can do is stabilize your wake-up time. You can't totally control when your body is tired enough to go to sleep, but you can control when you get up in the morning. And there's increasing evidence that stability around sleep, not only duration, is very important for sleep quality and preventing connected illnesses. And then you want to incorporate activities that promote sleep. So good sunlight during the day, exercise, a wind-down routine before bed, and avoid activities that can get in the way of sleep. So caffeine too late in the day, alcohol, as well as stress and worry. But if you're having trouble getting rid of that stress and worry, or you're very dissatisfied with sleep despite trying these things, use snoring and breathing pauses, I encourage you to seek out help. In sleep medicine, there's a lot of diagnostics and treatments that you can deliver to help both women and men with sleep issues. So thank you very much.
Thank you, Liza. That was great. I always make sure we have our arrow-proof podium when we say anything bad about alcohol up in Sonoma, so really appreciate that. It's a little less. I'm not saying to cut it out. Don't worry. Great. So that was a great introduction to what we want to talk about on the clinical side. Now we're going to move to sort of more clinical research and sort of cutting-edge research with Dr. Andrew Crystal. So Dr. Crystal is the vice chair of the psychiatry department at UCSF. He runs the research programs in psychiatry. And when we recruited Andrew from Duke and convinced him to come out to California, part of it is because Andrew's own personal expertise is that he's a world expert in sleep and its relationship with mood disorders and mental health. And so our sort of thinking about if we're going to tackle sleep, we want to do so in a very broad way that thinks of the entire patient, including its effects on and the bidirectional relationship with mood disorders. So with that, our next speaker, Dr. Andrew Crystal.
Thank you. Wonderful to have the opportunity to be here and to talk with all of you about sleep and depression, a subject that I work in and care a lot about. we have a fundamental flaw in the paradigm of psychiatry. It's the Humpty Dumpty model. In depression, we wait till a person has an episode of depression, and then after they've had impairment in their relationships and their job or school, things are not going so well in their lives, and basically their lives are falling apart, then we try to put the pieces back together again. We don't do such a great job. About 60% of people treated for depression in clinical practice achieve remission. The rest don't. That's not what is as good as we'd like to do. And there's a better way, an obvious way, right? Prevent it. Intervene before people's lives fall apart and prevent all of that suffering and degeneration of all the critical aspects of life. And the model for this is cardiology. They have hypertension. You measure blood pressure. It predicts future cardiovascular disease and institute a hypertensive treatment, diet, medication, and then it decreases the later development of these cardiovascular complications. Well, why don't we just do that in psychiatry? We can't. We don't know how. We don't have a toehold to stand on to sort of elevate us to that level. And I'm going to argue that identification and treatment of insomnia is actually have a lot of potential to be such a toehold, to be able to move us to a paradigm of prevention in depression. So almost everybody who has depression has sleep problems. 70% have insomnia. Almost the rest have sleepiness. I'm going to focus on the insomnia today. Historically, the belief was that insomnia is just a symptom of depression. We don't have to worry about it any more than we have to worry about sadness, especially, or loss of interest in activities. But it turns out, and that means basically just treat your depression with whatever means you use, medication, a cognitive therapy of some kind. There's been a lot of accumulation over the years of data suggesting that insomnia is a risk factor for future depression episodes, that it increases risk of relapse, and a bunch of correlative observations. In recent years, we have growing evidence suggesting that these relationships are actually causal and could be an opportunity to intervene. I am fortunate that Liza did some lovely groundwork for me in talking about this area. So we recently did a study where we delivered cognitive behavioral therapy for insomnia that you just heard about to women who had insomnia during pregnancy. We randomized people to that treatment versus usual care. And we found that that increased the rate of postpartum depression. So the people who didn't get the insomnia therapy had about a 20% rate of developing postpartum depression in the first 6 months. And the people who got it had 0. I'm not saying this is going to eliminate postpartum depression, but it's a positive sign. It's a strong indicator that this has potential. While we were doing that study, 2 other groups around the world were doing similar studies in other patient populations. They identified that, again, with cognitive behavioral therapy, you could decrease the risks of the emergence of depression in people who didn't have any depression to start with, who had insomnia, like blood pressure. Right? People with blood pressure aren't symptomatic themselves. Their blood pressure is elevated. You intervene and you prevent those symptoms from emerging. So one was over 1 year, one was over a 2-year period, and they all together show promise for the potential for moving to prevention. We did another study in a related area, which is suicidality, which happens in depression, but it also happens in other contexts. And there's I have on the slide 40 studies. There's actually now been over 100 studies that show that if you have insomnia at some point, your risks of developing suicidal ideation, of trying to end your life and actually succeeding in ending life is significantly elevated. Correlation. Is it causative? So we did a study to test that hypothesis. We found people who had suicidality and sleep problems. So they had thoughts about hurting themselves and they were having trouble sleeping, and we randomized them to a medication therapy versus a placebo. And we found that the medication significantly decreased their level of suicidality compared with the placebo. Again, suggesting that there's potential to do prevention, preventing people from committing suicide to start to have thoughts. You know, it's remarkable. This is such an effective predictor that it's actually more effective to assess whether a person has insomnia than to ask somebody if they're thinking about killing themselves. So these together, these observations suggest that insomnia, identifying it and treating it, is kind of like blood pressure. It has the possibility of preventing future adverse consequences and moving us to a preventive model. But how should we treat the insomnia? Well, you know, as Liza mentioned, cognitive behavioral therapy is the best strategy, but it's not used very much. A lot of times people get treated by a physician and get medications, but that's not how the world has historically or currently treated insomnia most predominantly. It's alcohol. And the good news for everyone here is that alcohol actually works a little bit. So on the first night of treatment, you can take a person who has insomnia and move them from having poorer sleep to somebody who looks like they have normal. The downside is it's not really a good ongoing therapy. So for a person who has occasional difficulty with problems with sleep, it can be helpful. But what's been found is that in a dose, the 0.6 grams per kilogram, that's high enough to actually improve sleep. By the sixth night of use, it actually doesn't do anything beyond what taking nothing does. And in fact, it takes people who have good sleep and actually can make it worse, particularly in the middle of the night. So it's not a great strategy, but at the same time, we have a number of options for medications that could be used. Obviously, cognitive behavioral therapy is preferred, but access issues and some people, because of not responding to it or other reasons, need some medication. And rather than alcohol, which has some downsides to it, the medications that have been studied rigorously and reviewed and approved by the FDA are available. I just show a little data to show that in contrast to losing effects in 6 nights, this is a study we did a number of years ago, showing that the medication ezopiclone, which is just one of many and is just an example, actually helped people every night, when taken every night for a year. It took, for 12 months, they took the medication. In the first 6 months, people were randomized to placebo or drug, and the drug gave people about 45 minutes to an hour more sleep per night than placebo. At the 6-month mark, the people who were on placebo got switched over to drug, but the people on drug continued on drug, and they maintained the same level of benefit. They didn't lose it over time. And so there are options that can help, that they're safe, and that can be employed when we find people who have insomnia. And I'm going to argue that insomnia is like hypertension. It's an opportunity for us to have a way to identify people at risk for mood disorders and suicidality, a way to intervene and to switch the paradigm to where we need to go in psychiatry for prevention. Thank you.
All right, just a reminder, we have one more speaker. If you could start getting your questions ready, and we'll pass them to the aisles right when our last speaker finishes. You know, I take care of a lot of folks with sleep disorders, or people who are seeing me for another reason and say, I can't sleep well. One of the things I often hear is, I think it just runs in the family. People say, my dad slept crummy, my sister sleeps crummy, etc. And we're really fortunate, because the next speaker we're going to hear from, Dr. Yingwei Fu, is probably the world's expert in laboratory-based research looking at genetic risk factors for sleep disease. And I'm not going to give this away, but Yingwei is going to tell us that some of this actually is in our genes, and therefore may also be a modifiable target. And then what she's also going to tell you, and I promised last year we would get to this, is some of her groundbreaking work that ties sleep with risk of and mitigation of risk for Alzheimer's disease and related neurodegenerative diseases. So let me introduce Dr. Yingwei Fu, who will be our final speaker today.
Thank you, Andy, for the kind introduction, and it's a pleasure to be here to speak. Before I start, because I heard you talk about it, I'm a breast cancer survivor for 18 years, so just so you know. So, okay, so we all are aware that there are some fears surrounding the topic of sleep because we all have heard how poor sleep qualities or not sleeping enough on a long-term basis subject us to have higher chance to encounter some problems later in life. Even though that's true, I hope by the end of today's talk or today's activity, we can convince you enough to replace most, if not all, of your fear with hope for the future. Because I do believe that we really have the chance to really crack this thing open. So what we are trying to do really is try to help everybody reach the goal of longevity to get good night's sleep. Now think about it. Every one of us actually spend about a quarter to a third of our life sleeping. So if we can use that time also help us stay healthy and live a longer, healthy life, it'll be like perfect, right? We don't feel like it's a waste of time anymore. And so, of course, we know that sleep remains as a mystery for the longest time until recent decades that we really start to have better understanding about sleep. Now, these are just some of the questions that people often ask me or doctors. Like when I go talk to people, they will say, well, what time should I go to bed? What time should I get up? How many hours should I sleep? And how do I know I get good night's sleep or not? And these are all good questions. And I think until recently, we start to be able to come up with some answers for some of these questions. So if we think about sleep behavior here, and now our sleep behavior is like many of our personal trait and behavior trait or personality trait. It has a distribution curve like this. We call this normal distribution curve. So if you look at the center of the bell shape of the center, most people here, if we just use how many hours of sleep, as an example, on the most left-hand side will be fewest hour of sleep people need. On the most right-hand side will be the longest sleeping need. And most people will fall in the middle, like around 7.5 to 9 hours of sleep. Now, as you get away from this middle range, you will have fewer people until you get to the very tail end of the most left-hand side or right side. A very small number of people who are very in very few hours of a lot of hours. And so what we have to do is taking advantage of this very tail end of people to help us understand how our sleep is regulated. So there are two different aspects of sleep that we are studying. One is about sleep schedule, and sleep schedule is all about what is the best time for you to go to bed, and what is the best time for you to get up that will be best for you. And the other aspect is about sleep duration. And sleep duration is about how many hours of sleep you get that will be best, not just for your cognitive function, but also for your total well-being. So after 20 years of intensive study from our group and also many labs in whole world, now we are starting to understand that our sleep schedule actually is partly, not entirely, partly regulated by our body clock. We actually, each one of us has a unique body clock that exists in every single cell of our body. And this body clock plays an important role in regulating our sleep schedule. Now, the other part is sleep duration. And we know that most people need somewhere around 8 to 9 hours of sleep because of a lot of reasons that a lot of us don't get enough of sleep. So the first good news I want to tell you today is that actually your sleep schedule or your sleep behavior is unique to your personal trait, like your height, or your skin color, whatever trait. It's uniquely yours because your DNA composition, environment you subject to. So you are the best person to help yourself figure out what is the best schedule for yourself and what's the best number of hours sleep you should get. And doctors like Liza and Andrew can help you, but you have a lot of control over this. So the good news is nobody can tell you when you should go to bed or how many hours of sleep you should get. So you have the total control over it. So that's the first good news. So then I want to tell you a very interesting things that we found from previous small number of people. We call them familial nature source sleepers. So these are people who lifelong sleep 4 to 6 hours. And when they are awake, they're very active and also live a long life. So after studying this kind of people for a number of years, we realized that there is a list of features that's very common for these nature short sleepers. For example, almost all of them are very optimistic, and they are also very active, and they are resilient to many different kinds of stress. And also, when they travel through many time zones, they don't experience jet lag like we do. Most people have severe jet lag, but they don't have these problems. And also, some of them have very high pen threshold. For example, when they go to dentist, they don't need Novocaine to help them manage the pain. And also, some of these people have like absolutely fabulous, fantastic memories. Now, most importantly is that most of them live a long, healthy life. Almost all of them live a long, healthy life. So after studying these people for a number of years, we were very positive. One thing, we knew that when we subject ourselves to long-term sleep disruption or not enough sleep, we have higher chance with all kinds of problems. On the other hand, we have this group of people who lifelong sleep fewer hours, yet they live a long, healthy life, an active life. So after a number of years, it occurred to me that the most logical explanation for this would be that actually their sleep quality or sleep efficiency is better than most people. And their good sleep quality and efficiency allows them to sleep fewer hours and stay healthy their whole life. So recently we have done experiments to prove this concept. And what we did was that we used Alzheimer's as an example, just as an example here. And we took Alzheimer mouse model, which we genetically engineered these mice to get Alzheimer. By 6 months, they have very severe Alzheimer. We put our short sleep mutation into this mice, we saw dramatically delay or prevent Alzheimer pathology. So I do believe that this Alzheimer is just an example. I do believe this is going to be true for many other diseases. So what this result told us is that when we look at sleep, we need to look at both quantity and quality together, right? The short sleepers, because their sleep quality is much higher than most people, therefore allow them to have fewer hours of sleep. I think the very important thing that the result told us is that we can actually use sleep as a tool to help us prevent or delay diseases, including Alzheimer and many other diseases. So what we have been doing now is that we have been using these genes and mutations that we found in these short sleepers to help us understand how our sleep is regulated, both at the molecular level and the neuroreceptor level. And you may ask me, why do we need to do all these things? And can we just figure out something to limit the short sleepers and help everybody sleep better? So I want to use this car as an example to tell you why. Now, when your car breaks down, ideally what you want to do is take the car to a mechanic who really understand your type of car. If you have an electrical car, you want the mechanics to know how different parts of the electrical car put together. So hopefully the person can fix your car and your car will run another 10, 20 years, right? In a very similar way, we need to reach to a certain level of understanding about how sleep is regulated so that we can come up with intelligent and effective to help everybody get good sleep and live a long, healthy life. So what we're trying to do is not just solve sleep problem for our generation, for us, also help solve sleep problems for all the future human generations, our children's and children's generations, and everybody live a long, healthy life. Thank you.
All right. Thank you very much, Ingwei. If folks have questions, please put them off to the side. We'll come around and collect some extra ones and bring them up my way. I'll get us started. It's amazing. I've got like 120 questions here. The good news is about 95 of them are about marijuana, CBD, or THC. So that's just Liza. Let's just get this out of the way because, like, they all want to know. An occasional gummy, THC, CBD. Is there any evidence that this helps sleep? Is it something that you recommend?
Yeah, it's a good question. I'm actually wondering the same thing. Patients come in all the time asking this and having taken it. And it does seem that they can help with sleep, but we really are missing high quality, large scale studies to give good recommendations. So we're kind of stuck in a clinical context into saying, I'm not sure. If it seems to be helping you, or if you've tried a number of other things, not unreasonable to try, but I can't make a strong recommendation because we just don't have good research studies.
I think one of the things that's been interesting is that despite the importance of sleep and sleep medicine, it's one of the more underfunded areas of medicine. And you've got three of the more famous researchers in the world here lined up to my left, and there's just not a lot of opportunities for funding from governmental agencies, et cetera, to tackle these problems. So Liza and I were talking, we kind of had ahead of time that we get a few questions on this topic on THC, CBD, et cetera. And we were, musing that this is a study that would be easy to do. It's funding that is often the limitation. So that's a good lesson. So don't know yet. Anecdotally, it works for some folks.
Yeah, it does seem to help some folks, but the kind of long-term effects and the safety and exactly how it might change sleep architecture and what components contribute in what way, we really don't know.
Okay, Andrew, let me give you a practical one. A lot of people take, and there are about 3 or 4 questions. I'm synthesizing them together. A lot of people take an occasional Ambien. This isn't every night, but when there's a time that they need to get to sleep, if they're having insomnia, Ambien or a related medicine. Is this okay? Does it have long-term effects? Is this something that you say for occasional insomnia, it's fine to do?
Yeah, this is a great question, and it is, I think, very clear that taking occasional Ambien or related drugs doesn't seem to have any adverse effect. However, the drug, by design, intent at least, has some effects that can put a person at risk. That is, they blunt consciousness, that hopefully helps you fall asleep and stay asleep, and affect balance and memory. And so when the drug is working, there is a risk to a person that they can have a fall or have an event like confusion or something like that. So because every drug has side effects. That is not related to using it frequently or infrequently. It's just a risk that's associated with that medication. There's no evidence that taking it acutely or even every night for a year, there's a study with Ambien every night for a year in addition to the Zopiclone study I talked about. And there was no evidence. Now, if you took it every night for 10 years, there's no way to know. There's some correlational data out there about long-term adverse consequences related to degenerative disease, but those studies are really hard to interpret because they don't address the fact that people who have sleep disturbance may be at elevated risk for developing neurodegenerative conditions. So the answer to that question is basically, it's fine as long as you're aware that there are risks of using a medication of any kind.
Right. Anyway, a lot of what we sort of hear about, you mentioned everybody's unique. So some people need 8 hours, some people need 6 hours, et cetera. But there's another part to your research that I'd love you to talk about, which is that, we always talk about a good bedtime, a good wake up time. And Liza, said, let's all wake up at the same time. But I think some of what you've discovered is that genetically, there are people who stay up late, and there's people who wake up early. Tell a little bit about that work, about how there are genes that define whether we are night owls or not.
Yeah. So, so that's a part of the study that we study for look at sleep schedule. So, in fact, our genes, our genetic composition, affect our sleep schedule, right? And so, some people have mutations that make them want to go to bed very early, like 6 p.m. or even earlier, and get up in the midnight or somewhere around midnight. And some people have genetic mutations that make them want to go to bed early in the morning and sleep until afternoon. So that's very strong genetic components make them that way. But I think almost everybody has, depend on your genetic composition, it will make you have your best schedule. So now we always say that the example we always say that is that if you tell people to always go to bed 10 o'clock, get up 6 o'clock, it's like saying everybody needs to be 5'3", which is perfect for me because I'm 5'3", but maybe not good for you. So it depends on your genetic composition. That actually is a little bit different, and that everybody should try to figure that out for themselves. Yeah.
Right. Liza, here's one for you. You mentioned snoring. That's a sign for some people of sleep apnea. I got a couple in here. Is snoring always bad? Or is there some forms of snoring that don't mean you have obstructive sleep apnea? In other words, if my partner is snoring Is that a reason to get that partner to see a doctor?
Yeah, interesting. I think that's a good question in the context of what I shared to elaborate there. So we think about sleep disordered breathing as kind of a spectrum. And we know sleep apnea, especially when it's more severe, is clearly linked to negative health consequences like increased risk of heart attack and stroke. There's a relationship with neurodegenerative disease that we're still trying to define. And then there's a spectrum with snoring at one end. And snoring does indicate that there's something going on in the airway to create a noise. But what's happening in sleep apnea is the airway's collapsing enough to actually make the oxygen drop and to wake people up. And if it's snoring alone, we don't think that someone's waking up or the oxygen is dropping. So it doesn't have that risk. But snoring alone has been associated with increased sleepiness as well as increased risk of high blood pressure, even by itself. So, and people who don't have sleep apnea. So there probably is some risk, but in terms of like insurance covering interventions like CPAP, they won't if someone has snoring alone. I think the question of should I get my partner evaluated depends on their symptoms. So if they're only snoring but they feel great about their sleep, they're not feeling sleepy during the day, it's probably fine to not be evaluated. Unless maybe they've had a heart attack or stroke or have really difficulty to control blood pressure. But if they're feeling drowsy, they feel like their sleep is really unrefreshing, or you actually hear breathing pauses, I would recommend evaluation.
Great. A number of referrals coming your way. Andrew, how about some rapid fire things we hear about that are bad for sleep? I'm going to do 2 or 3 real fast. 1, looking at my phone and screen time right before bed. Something I need to avoid. I do it every night.
Well,
I'm not asking you to diagnose me. I just want good general advice.
I'm guessing that you are a good sleeper. You don't have difficulty having disturbed sleep. And I think this is a real frustration for people who do have sleep problems. Because they can see you doing that and you are just fine. But people who have a predisposition to sleep problems can't. It's like napping. It's fine for many people. But if you have a disturbed sleep at night or a predisposition to that, it's not a good thing. But it can otherwise be just fine. So I think doing things like looking at your phone or being engaged in work is a tremendous problem for some people. They start to worry, it gets them all stressed, and then they don't sleep well. But other people, so just for those, just because it's not universal, it's important for people who have insomnia to realize that they're prone to insomnia, that it differs among people whether it causes problems.
Andrew, you or maybe Liza said it. I think you said it. Caffeine right before bed, avoid it. What does that mean? How many hours last cup of coffee before bedtime? Is there a right answer to that, roughly?
Well, so there's a lot of individual variation in the response and how sensitive people are to caffeine. You will all hear people, or maybe you know people who say, I drink a strong cup of Starbucks coffee just before sleep and I'm just fine. But then you hear other people who say, like, I just walk near the coffee and I get a little sniff of it and I don't sleep for 2 days, right? So you have to, like most things, it's like in way illustrated so eloquently, a lot of it is variation with genetics probably. And so a general principle, caffeine disrupts your sleep and it lasts longer than we think, especially in subtle ways. And I recommend no coffee or things like that after noon in people who have difficulty with this.
There you go. Andrew, one more then. How about alcohol? Let's think about it in the type of alcohol that usually may be helpful for insomnia. That's is it at dinner? Is it as an after dinner drink, an hour before bed? Give us a sense of timing if you're going to use that occasionally for helping sleep.
Yeah, I mean, if you're going to use it for helping sleep, it's better used near bedtime. But in most people's lives, they have it with meals, typically dinner, and that's just fine. You know, if you were a person who said, I'm having trouble sleeping at night, and you were telling me you were having alcohol every night with dinner, I'd say we should try not having that. But I want to emphasize a couple things. It's sort of like, is it okay to take an Ambien every now and then or use alcohol every now and then if you have sleep trouble? You have to weigh whatever risks exist versus the suffering you have with your problem. if it eliminates, if you're using CBD, let's say, and it helps you, and you don't have side effects of it, and it helps you feel better and function better, I think it's worth it, right? But each person has to make that decision on their own. There's always risks and benefits of every kind of sort of intervention like that. So, like, I've had people who have a nightly drink and alcohol, and they're worried, they're not sleeping well at night, and they're worried about it, and we have a discussion about what's the quality of life benefit to you from the drinking the glass of wine from Sonoma here every night? And they say, I love it. It's such a tremendous joy for me in life. That you have to weigh against any kind of adverse consequences and specifically what they are for you.
Great, thanks. Ingwe, you talked a little bit about Alzheimer's disease. You might want to expand on it. We got a couple questions about Parkinson's and sleep, that some people at the beginning of Parkinson's disease have more trouble sleeping. Are you guys looking at all of the relationship between Parkinson's and sleep?
So this is interesting because a lot of neurological diseases have sleep problem, right?
As part of the disease.
As part of the disease or early symptoms, which I think for me is easy to see because it's in our brain. It's all these very complex circuits control all different parts of the brain. Our brain is very complex. So when you have and in sleep, it's kind of a network thing. It's not just one thing, right? It's a whole bunch of different parts work together. So if you have one part of a problem, it may later on develop into Parkinson or the other part develop into whatever diseases. But it kind of interfere with the network that's regulating our sleep, and therefore sleep will become one of the symptoms that almost all neurological diseases have. We have not started to work on Parkinson's specifically, but I would predict that if we look, it will be something very similar to Alzheimer's that we can also, prevent these diseases progress. So,
Liza, somebody asked, you mentioned CPAP as an important treatment for somebody who has sleep apnea, but golly, I can't stand the mask is what I heard. So are there other non-CPAP treatments for apnea that exist or are being developed? We hear all sorts of things on TV and on the radio. What types of other non-CPAP apnea treatments do you recommend or in the future?
Sure. So this comes up in clinic all the time. CPAP is a wonderful treatment because it's very effective if you can wear it. A lot of people struggle to wear it. There has been evolution over time in the quality and shape and fit of the mask. But in terms of alternatives, for mild and moderate sleep apnea, one of the main alternatives that's been around for a while is an oral appliance, or we'll call mandibular advancement, that pulls the lower jaw forward, which is connected to the front of the airway, and therefore pulls the airway open.
You take it in and out, or it's there permanent?
You take it in and out. It's like a bulky retainer, but you can't close your mouth normally. Instead, you close your mouth with your jaw pulled forward. Not quite good enough for severe sleep apnea, but can be good for mild and moderate sleep apnea. Advertised on TV right now is Inspire, the simple muscle nerve stimulator, which has been around for 10+ years, but they really doing a big advertising push right now. So it's all over. People are coming and asking about it a lot. I group that with the surgical treatment for sleep apnea. It's a stimulator that's implanted, so it requires a procedure, a small surgery, and then a stimulator goes to the tongue and adjusts the tongue during the night. It is not as effective as CPAP, but it's a good alternative for people who failed CPAP. And there are other surgeries that are also used for CPAP. Weight plays a huge role. So weight loss can help. Those are really the main treatments. There are other things like daytime tongue stimulator, nasal valves that help a little bit, but probably don't really adequately treat sleep apnea. Many people are waiting for a pill to just cure it, but we aren't there.
There are a lot of questions about melatonin. People, again, take that occasionally. Is that like Ambien? Is it just as good? Is it something you recommend? Or is this something you don't have evidence for, like the CBD?
Melatonin is a hormone, and it is released by the pineal gland when it gets dark for us. And it probably plays some role in facilitating sleep onset. But its biggest role for us as practitioners of sleep medicine practice is that it tends to set the time at which you sleep and move the time at which you sleep. So most use it. Let's say for somebody who tends to stay up late and sleep late, we give it about 4 hours before their bedtime and then slowly move it back as a way to help, along with light therapy in the morning, to try and shift optimal time of sleep. It has been studied in a large number of studies to see whether it works like Ambien. It helps people fall asleep faster. And it works a little bit, but not enough to be clinically meaningful in the global group. This is in medicine. There was a huge advance by the double-blind placebo-controlled trial, made a big difference in helping us understand things. But what it tells us is what the average looks like. It doesn't tell us about you, like, or the person who's in front of me when I'm in the clinic. And I have some people say, oh, I take melatonin and it made a huge difference in my life. So it probably has variation, but on average, the effect size is too small to be clinically meaningful.
Great. Anyway, I've got two more for you. One, and I'm glad you guys did it and not me, because geneticists hate when I ask these questions, which is why. So, Ingwe, you mentioned that there's a small number of people you've identified who only sleep for a few hours a night and are fine. Why has that not, through evolution or whatever, become like a thing for all of us? Like, what does that gene do? Like, why does that exist in some people and not in like a lot of people? That's question one. I'll come to two in a second. These are both impossible. Go for it.
Okay. So the best answer we can come up with about this is that if you think about it, before the electricity was invented, the light is always available. There was no advantage to be able to stay awake for a long, long time. In fact, if you when people were living in a tent, if you go outside in the dark, you probably will you will get eaten by bears more likely than people. So there was no advantage to be like this. So these are newer, evolutionary newer mutations. That's the best answer we can come up with. So it's a small number of people.
And then last one for you, and then I want to ask Liza a final question. So the last one for you is, can we find whatever this is doing and bottle it and sell it? Is this
That's
part of the
goal.
research? What are we trying to do?
That's the goal. That's the goal. Let's really understand why, how, because like Liza said, that there are many functions when we sleep. Our body actually works very hard when we're sleeping to help us stay healthy. And we have to understand why these short sleepers, all these functions perform better. Now, if we can get it to a certain level of understanding, then hopefully we can bottle it up, make it into a pill, and we can all sleep better and get good sleep. And
we'll take it. It's great. Liza, let me ask you one final question before we stop, since we're at the top of the hour. A bunch of us have some sort of sleep tracking app on our phone or one of those little rings that we're wearing. I'm sure there's a few around here. Are these things that you recommend? Is this helpful, or is this just make us more anxious about how much we're sleeping? What do you tell patients?
I think that you could find a bunch of different folks in the field of sleep medicine to give both sides of that argument. I think it's an active debate. Overall, these are becoming more popular. I think they're wonderful in getting people to really think about and recognize the quality and importance of their sleep. And they're not going anywhere. They're only becoming more and more prevalent, and probably they'll be incorporated more and more into clinical decision making. But right now, we're not at a stage where we can really understand how they correlate with the studies we do have, an in-lab sleep study. We don't know the quality of the data a lot of them provide, because they're constantly updating their algorithms, and the research teams trying to validate can't keep up. And they're not really directing themselves at clinicians. They're directing themselves at the public. And so they don't need to publish studies that validate them against what we consider the gold standard of an in-lab study. But I do think that they can be valuable for someone to try to get what is the right amount of sleep for them each night. And I think we'll find ways to incorporate them over time. With the caution that I do think you mentioned, can they be problematic? Sometimes they can. Sometimes for someone with insomnia who isn't sleeping 8 hours but feels convinced they need to, they can create more problems. So I think it's on an individual basis whether they're useful.
Fantastic. I want to thank all of you for coming. I want to thank Andrew, Ingwe, Liza for a great presentation.
Wow. Thank you all so much, Dr. Ashbrook, Dr. Fu, Dr. Crystal. Really appreciate you coming out and sharing your time with us in Sonoma and your expertise. And one who brings it all together for us, Dr. Josephson. Really appreciate everything you do to make this event happen. So thank you. And since we established that booze is good for your sleep, we actually have a bottle of wine for you in the back. The San Giacomo family Chardonnay and a bottle of olive oil from one of our board members' property. And so I think there needs to be a study on all the effects of olive oil on sleep.
Okay.
Appreciate that.
Okay.
We'll do that.
Something like that. So, I'm Dave Fear. I'm the executive director of the Hospital Foundation, and I can't tell you how much I appreciate you all being here today with us and being a part of this wonderful event. And our primary focus, as you can tell, is on the educational aspect of the day. And we can do that because all of the fundraising is done on the front end. So the sponsorships and the patrons and the individual tickets, that'll be possible to have that fundraising happen on the front end. And Sherry mentioned a little bit where the fundraising is going. We'll just clarify in just a second. But I want to call out a special thanks to our lead sponsors, Union Bank and UCSF Health are both our lead sponsors. So thank you. They've been doing that for years. And the catering this year was actually generously underwritten by Joan Weil and Union Bank. So that also goes a long way. And we have a number of angel patrons that I'd like to name. So we have Joan Weil, Kimberly Blattner, Sherry Hughes, Ramel Perkins, Elizabeth Seeley, and the Videz Family Foundation all help make a lot of the fundraising possible. Thank you. And specifically where it's going this year, so we were able to buy the hospital a new X-ray, which is a breast scope camera, and 4 new EKG machines that are compatible with the SVHF MyChart platform, which is a big deal. And in addition, supporting the ongoing efforts for Project Pink that Sherry mentioned earlier, which is the free mammograms and ultrasounds and biopsies that we try to provide for women that cannot afford them. So thank you all for making that possible. That's your generosity. A shout out to the Haystack Farms and Wildflower Group. They put together all the bouquets and they're lovely, so thank you to them. And then finally, just thanks to all of the hospital leadership and staff that came here to volunteer today. We appreciate what you all did. We've got more dessert outside for social time. All of our speakers are going to stay, so if you want to stay and mingle, they are available to answer any additional questions that you may have of them about sleep and all that it pertains. So look forward to seeing you next year. Thanks for coming.